Sir, we're good to go.
Hi friends, welcome. Hi friends, welcome to yet another episode of Innovations in Hematology, session 7. Today is a very interesting lineup from Dr. Meera Mohan, who has done extensive work on risk stratification of multiple myeloma and has been working for almost a decade in the field of myeloma and making us enriched with her experiences of what they have done in these many years. Dr. Nikhil has been spearheading this wonderful series for past 6 months. I think the amount of love, respect, and attendance all of us has shown towards this is a remarkable phenomena for all of us. From every time, 200 to 500 plus people attending these webinars shows the interest of not only Indian audiences, but doctors across 40 countries joining in to understand and unravel the mysteries of the diseases so that each and individual can live longer and potentially achieve cure. So with this, we hand over to Dr. Nikhil for further proceedings. Thank you, Dr. Nikhil.
Thank you, Dr. Bhargav. I welcome all of you to today's webinar on risk stratification in multiple myeloma. This is something which has evolved over the years, and we have seen more and more markers and innovative technologies coming into this space. So before we go ahead with that, I would like to briefly tell our audience about our approach when it comes to newly diagnosed as well as relapsed multiple myeloma patients. So we do a basic serum protein electrophoresis, light chain assay, immunofixation, along with a bone marrow aspiration, biopsy, and myeloma FISH panel for all patients, both at diagnosis and relapse. We use both the RISS as well as the MSPART risk stratification to make treatment decisions. We, however, do not do conventional cytogenetics for all our patients. Of late, for few of our patients, especially patients with a refractory disease and who have relapsed and not responding to conventional treatment, we have been trying to do an NGS. This has thrown up more questions than answers. And many a time we end up picking up something which is a chip. And the significance of this is something which we have to discuss further. So for today's webinar session, we have with us Dr. Meera Mohan, who is an assistant professor in the Department of BMT and Cellular Therapy at Medical College of Wisconsin. Dr. Mohan completed her fellowship in hemato-oncology and training at the prestigious University of Arkansas for Medical Science. She has worked and trained with some of the leading myeloma experts at the prestigious Myeloma Institute of Research and Therapeutics at the University of Arkansas. She has numerous publications in both national and international journals. During her fellowship, she was awarded the Career Development Grant from the Conquer Cancer Foundation, Annual Meeting Merit Award, and the Editorial Fellowship from ASCO. Her primary focus is to design and conduct clinical trials geared towards improving outcomes in multiple myeloma. I would hand over the session to Dr. Meera Mohan. Over to you, Dr. Meera. I have stopped sharing my screen. Dr. Meera, I think you're muted.
Yeah, thank you, Nikhil, for the kind introduction. I hope you can see my slides.
Yeah, your slides are visible. Perfect.
Okay. All right. So good evening. Thank you, the organizers for this wonderful opportunity. So over the next 35 to 40 minutes, I'll try to go over risk stratification in multiple myeloma, what is new in 2024. These are my disclosures. So multiple myeloma, as we know, is a malignant disorder that arises from plasma cells, which are terminally differentiated B lymphocytes. So the slide here shows the characteristic lytic lesion that defines multiple myeloma. And we also have this beautiful figure that shows the clonal evolution that we see from the MGUS to the relapsed refractory state. This is from the excellent review by Dr. Morgan and colleagues in the Nature Review Cancer series. So I would, it's worth a read. So coming to diagnostic tools that we use in a day-to-day clinical practice. So all patients who are referred to us for multiple myeloma, I mean, we only see patients with multiple myeloma, so they should have an established diagnosis before coming in. But in a patient with suspected plasma cell dyscrasia, these are the investigation that I typically order. Serum protein electrophoresis is used to detect the M spike in the serum. The M spike refers to a large amount of monoclonal IgG protein. We always order a serum immunofixation along with the SPEP. The idea here is that SPEP is based upon a charge base of the protein on gel, and it has a low sensitivity and can miss small amount of M protein and light chain. So the serum immunofixation helps us detect small amount of M protein when the SPEP is negative. In addition, it also helps us determine the subtype of M protein. Here we can see that the serum immunofixation shows an IgA lambda subtype. Serum-free light chain assay is something that we also routinely order in our patients with multiple myeloma. So we know that the clonal plasma cells makes the same amount of monoclonal protein and also produces extra light chain that does not have a heavy chain partner. So the serum-free light chain assay is used to detect the free light chain. It's important because if we don't order this test, we will be missing nearly 10 to 15% of myeloma that secretes just light chain. Additionally, we will also be missing AL amyloidosis, which can present with just an elevated light chain. Kappa lambda ratio refers to the abnormal ratio of the free kappa or lambda light chain and indicates excess of one type of clonal plasma cells due to multiple myeloma. So this is the entire clinical spectrum of plasma cell dyscrasia. I'm sure the audience is well aware of that. So we have a precursor condition called MGUS that's present in roughly 3 to 4% of patients over the age of 50. And then we have the full-fledged multiple myeloma. Smoldering myeloma is an intermediate state between MGUS and active myeloma. It's characterized by a higher tumor burden. We see here the serum M protein of more than or equal to 3 grams per deciliter, clonal plasma cells between 10 to 60% with no myeloma-defining events. So in 2024, the International Myeloma Working Group has introduced 3 biomarkers in addition to the CRAB features that can now define multiple myeloma. The 3 biomarkers include more than or equal to 60% clonal plasma cells, a free light chain ratio of more than 100%, and MRI-defined focal lesion that's presence of more than one focal lesion, more than 5 mm in size. So currently, we define multiple myeloma with the slim CRAB criteria. So we've gone away from the concept of end organ damage definition for multiple myeloma. So coming to a case study, so I'll try to go through the risk stratification based upon a case here. So Mrs. X is a 77-year-old lady with who's of African-American ethnicity. She presents with 6-month history of worsening thoracic back pain. X-ray shows a small lytic lesion. She has a long-standing history of systemic hypertension, which is well controlled. Her performance status is excellent with the ECOG performance status of 1. So I just wanted to point out here that the epidemiological data reveals that African-American patients are at 2 to 3 times more at risk for multiple myeloma compared to our European American colleagues. So how do we proceed here? So the initial consult, how do we stratify these patients? How can we adapt treatment? So this is a workup that we do for our patient who presents in the clinic. So they will get CBC and BMP. This patient here has anemia with a hemoglobin of 9.2, calcium is 13.5, serum albumin is low at 3.2, beta-2M is elevated at 4.2. The peripheral smear here shows relay formation, which are linear aggregates of red cells that occur in the presence of an elevated plasma protein level. Bone marrow biopsy reveals 70% plasma cells that are clonal. FISH studies reveals hyperdiploidy in 55% of these cells. SPEP shows an M spike of 3.8 grams per deciliter. we see that the serum free light chain assay showed an elevated kappa light chain at 2,550 ml per liter. Immunofixation confirms IgG kappa subtype. In addition, the patient also had PET-CT and MRI drips, which shows no evidence of focal bony lesion or extramedullary disease. So coming to the topic here, risk stratification in multiple myeloma, it is truly revolving at this point. So why is this important? We know that high risk and ultra high risk disease is a very challenging disease to treat. High risk disease takes up about 30% of newly diagnosed multiple myeloma. The proportion of patients with high risk disease increases with each successive relapse. High-risk disease is a significant cause of mortality in multiple myeloma. And unfortunately, the current therapies, including CAR-T and bispecific antibodies, have really not shown significant improvement in outcomes in that high-risk or ultra-high-risk disease population. So what are the factors that affect outcome in multiple myeloma? We can broadly divide them into disease, host, and treatment-related factors. The disease-related factors include plasma cell-related factors such as genetic abnormalities detected by our FISH studies or gene expression profiling studies, serum LDH, circulating plasma cells. Plasma cell proliferation index is really an obsolete test that was used in the past. Currently, it's not something that they use in the clinic. I also want to introduce the idea of novel imaging. So novel imaging is an important prognostic tool that we use in patients with multiple myeloma. So focal lesions refer to bony focal lesion, which are aggregates of myeloma cells in the skeletal system. These can be detected by novel imaging studies, both PET-CT and MRI. Extramedullary disease, as we all know, is another important prognostic marker in multiple myeloma, and this is best detected by a PET-CT diagnosis. Host factors such as age, performance status, especially frailty of a patient, as well as medical comorbidities are important considerations and can affect outcomes in our patients with multiple myeloma. In coming to the treatment-related factors, response to therapy is an important predictor of long-term outcome. We know that duration and depth of response, particularly the minimal residual disease status or MRD status, is an important predictor of both progression-free and overall survival. We're also aware of transplant eligibility as one of the factors that affect outcome in patients with multiple myeloma. So with the introduction of quadruple therapy, even quadruple therapy in patients who are transplant ineligible, we're really questioning the transplant eligibility criteria, and we're going away from using that term and replacing it with quadruple therapy eligibility criteria. So this is a very simple slide that shows the overview of genetic abnormality in multiple myeloma. So we can broadly divide them into hyperdiploidy. Sorry, we can broadly divide them into primary genetic abnormality and secondary genetic abnormality. So primary genetic abnormalities are those that are established at an MGUS state, that they produce a dominant clone, and then they are universally present within the myeloma cell of an individual. Secondary abnormalities are those that are acquired as the disease evolves from MGUS to multiple myeloma to the relapse state, and they produce a diverse subclonal disease. The primary genetic abnormalities can be divided into hyperdiploidy and non-hyperdiploidy. Hyperdiploidy refers to gain in the odd chromosome, as we all know. Non-hyperdiploidy is pretty much those translocations. The translocations include 1114, 414, 1416, and 1420. So just briefly about 1114, we know that this is now a standard risk feature in multiple myeloma. It's an important subgroup accounting for about 15 to 20% of all newly diagnosed multiple myeloma. This is also an important group because now we can target this with venetoclax, which is our precision medicine. Additionally, we know that a subset of patients with 1114 translocation can also express CD20. So this is what we call the group that can behave like MGUS. So these are patients that have the lowest response rate but have excellent outcome. 414 translocation accounts for about 10 to 15% of myeloma. I'll be going over what is new in 414 translocation. A subset of patients with 414 translocation really have poorly behaved myeloma. 1416 and 1420 are rare translocations, and there's a bit of a discrepancy as to what is included as high risk. The European colleagues don't consider 1416 as high risk disease, while the Mayo Clinic mass risk stratification score has incorporated 1416 as a high risk feature. So we'll be going over that as well. Secondary events include primarily abnormalities in the chromosome 1, such as 1q21 gain and deletion 1p, and 17p deletion, including TP53 mutation, is a high-risk feature in multiple myeloma. So we know that the plasma cells have a low proliferative ability. So this can interfere with karyotyping. Although we do cytogenetic abnormalities, it's something that we do routinely in our clinic, the yield is pretty low. So this is where FISH comes into play. FISH, or fluorescent in situ hybridization, is a standard test offered to all patients with newly diagnosed as well as relapsed refractory multiple myeloma. So we know that there is variations in the plasma cell enrichment method, prop selection, as well as cutoff values, producing substantial difference in the prognostic significance attributed to cytogenetics detected by FISH. FISH can detect both primary as well as secondary genetic events in plasma cell clone. FISH can be done in resting cells, but it will only yield information depending upon the props that we use. So the caveat with FISH is that you'll only find what you look for. So this is an example of the FISH panel that we use in our institution. We look for the standard translocations for 1411, 1416, and 1420. Additionally, we also look for secondary abnormalities, the 1q1 gain, deletion 1p32, 17p deletion. So these are the standard FISH panel that we do. The cutoffs again vary, which I'll be going through in the subsequent slides. So there was a question about what is the value of next generation sequencing in multiple myeloma. So we know that when we do next generation sequencing, as Nikhil pointed out, there are more questions than answers. So it can yield many mutations, and really the clinical significance of some of these mutations is largely unknown. So next generation sequencing is really not done in a routine clinical practice. But then there is one notable exception where I might consider next generation sequencing. So this is to detect what we call a biallelic TP53 event. That is, when you have deletion of one allele of 17, that is 17p deletion. In these cases, the other allele might be involved by a mutation of the TP53. So if we were to do next generation sequencing, we can detect those patients who have a biallelic inactivation of the 17p gene. And this accounts for 4% of newly diagnosed multiple myeloma. We know that these patients have an extremely poor outcome. However, at this point of time, really, we don't adapt treatment based upon the risk of the patient. So patient who come in see us, they do get the quadruple induction, which is currently the standard of care, and patients who are eligible for transplant, we proceed with upfront transplant. I mean, there is this concept of delayed transplant, but it varies from institution to institution. So we are a very transplant and a cellular therapy heavy center. So we offer upfront transplant for all of our eligible patients. So this might come into play as we have, CAR-T and bispecific antibodies that are slowly moving into an upfront setting. So in that setting, maybe the value of next generation sequencing routinely in the clinic might make sense, but currently that is not something that we do in the clinic. So this is actually a slide from this chapter by Dr. Matthew Rees and colleagues at the ASCO Educational Book of 2024. So it's pretty much summarizes the primary and secondary abnormalities. And actually, this is a good read. And if you all are interested in immunotherapy, CARs and bispecific, we also have a book chapter in the same ASCO Educational Book. It's actually free, available for download. You don't really need to subscribe. It's the ASCO 2024 book. So coming to 414 translocation in multiple myeloma. So are all 414 in multiple myeloma the same? The answer is no. So 414 translocation is only considered a high-risk feature if it is associated with other abnormalities such as 1q21 deletion 1p or deletion 17p. So this is the new IMWG consensus definition. I'll be going over that as well. But standalone, 414 is considered a high risk, but not a ultra high risk feature. So this is actually a very recent publication by the European colleagues. In this study, they included 258 patients with FISH-confirmed 414 translocation across various clinical trials. So this is a very heterogeneously treated patient population. Some patients did receive VRD induction. There was a varying maintenance approach, but all patients did receive an autologous stem cell transplantation. So the patient samples, bone marrow samples, were subjected to whole genome sequencing and transcriptomic analysis. So using this approach, they found that patients with 414 translocation can be stratified into 3 groups with distinct outcomes. So the outcome of patients with 414 translocation really depends upon the translocation breakpoint located in the NSD2 gene and the expression of the IGH NSD2 fusion transcript. So here we can see that this group here is a group that's labeled as no disruption. So these are patients with 414 translocation. Nearly half of the patients belong to this category, and they have an excellent overall survival of 75 months. So here, the translocation breakpoint occurs upstream of the NSD2 gene. So the gene as such is not involved in this group. And intuitively, they have the best outcome. And then we have 2 other groups here. The early disruption involves the breakpoint in the 5-UTR region. So thus, they have an intermediate outcome between these 2 groups. The overall survival is nearly 60 months. And then we have the late disruption group, which is about a third of the patients. The overall survival is actually poor at 28 months. In the late disruption group, the translocation breakpoint actually involved the NSD2 gene. So thus, in this study, they've shown for the first time that the clinical utility of the NSD2 breakpoint analysis is an additional tool that can help us identify and risk stratify patients with 414 translocation. So not all patients with 414 translocation behave the same. And it's only a high-risk event if it is associated, ultra-high-risk event if it's associated with other secondary abnormalities. So coming to the 1416 translocation, we know that this is also a high-risk event as per the new International Myeloma Consensus definition, but it's only considered an ultra-high-risk event if it's associated with other secondary abnormalities as shown here. So this accounts for 3 to 5% of newly diagnosed multiple myeloma. And we know that this subgroup as such is enriched in the APOBEC mutation signature, which is really a high-risk signature described by Dr. Walker and colleagues a few years ago. This translocation is enriched in patients with renal failure, and that's why these are patients that are underrepresented in clinical trials, because we know that clinical trials have a very strict inclusion and exclusion criteria, and traditionally most clinical trials exclude patients who have baseline renal failure. 1416 translocation is also enriched in patients with primary plasma cell leukemia. So this is from a recent publication from the IFM that included nearly 170 patients with 1416 translocations. So what they found here that 1416 translocation is actually enriched in other abnormalities, particularly 1q21, which is seen which is shown in the diagram here. So they also found that overall, patients with 1416 had a worse outcome in terms of progression-free and overall survival compared to patients who did not have 1416 translocation. That is the black curve here. However, this is driven largely by patients who had secondary abnormalities, that is 1416 concomitant with other abnormalities such as 1q21 deletion, 1p or 17p deletion. And patients who did not have secondary abnormalities, that's shown here by the dotted blue curve, had outcomes that was not significantly different from patients who did not have the 1416 translocation. Thus, taking all this together, the new International Myeloma Working Group Consensus definition defines 1416 as a high-risk event only if it is present with other secondary abnormalities. Now, coming to the 17 deletion and TP53 abnormalities in multiple myeloma. So we know that deletion of short arm of chromosome 17 is a well-established high-risk feature, and it is included in the current disease staging criteria. One of the controversies with the 17p deletion detected by FISH is that various groups have shown different cutoff values of clinical significance. So currently, the IMWG consensus definition accepts 20% cutoff as the FISH cutoff for 1715 that correlates with clinical significance. I also wanted to introduce this concept of monoallelic and biallelic event. So we know that there are two alleles in the chromosome 17. So monoallelic event is when you have involvement of one allele. So this can happen with either deletion of 17p or just mutation of, as shown here, mutation of the TP53 gene located in one of the alleles. So biallelic event is described as events that occur in both the alleles of the chromosome 17. So this can occur in three ways. The most common is when you have deletion of one of the alleles along with mutation of the TP53 in the other allele. And the other ways by which we can have a biallelic event is if you have deletion of both the alleles or mutations of both the alleles, which are really not that common. This is actually a big meta-analysis that included nearly 1,000 patients coming from our European colleagues. They showed that indeed the concomitant presence of deletion 17p and TP53 mutation confer poor outcome in patients with multiple myeloma. And patients who had either of these abnormalities had an intermediate outcome as shown here in the blue curve. I also wanted to introduce the concept of double hit multiple myeloma. So this was actually coined by Dr. Walker and Dr. Morgan in their pivotal paper in Leukemia in 2019. So double hit myeloma accounts for 6% of newly diagnosed multiple myeloma. This is defined as patients who had ISS stage 3 disease along with either biallelic TP53 events or amplification of 1q21. Amplification is 4 or more copies of 1q21. So this subset of patients, as we see here, have an extremely poor outcome with a median progression-free survival of about 15 months and overall survival of about 20 months. Now coming to the chromosome 1 abnormality in multiple myeloma. So chromosome 1 abnormalities include 1q21 copy number alterations, that is gain and amplification and deletion 1p. So gain is defined as 3 or more copies and amplification is 4 or more copies of chromosome 1q21. So currently biallelic deletion of 1p is an ultra high risk event in multiple myeloma, but the rest of it is just a high risk event. So this is one of our publications that we presented at ASCO of 2019. So this included about 1,000 patients treated on the total therapy clinical trial protocol, where we showed that both gain as well as amplification of 1q21 was associated with inferior progression-free and overall survival. And this was true on multivariate analysis incorporating well-established risk factors. And this is another study from our French colleagues that included 2,500 patients with newly diagnosed multiple myeloma. They showed that 11% of patients had a deletion 1p32. They actually had two important messages in this paper. One, that biallelic deletion 1p32 conferred a dramatically poor outcome compared to a monoallelic event. You can see here that this is the red curve represents a subset of patients with biallelic deletion 1p32 compared to the orange curve, which is the monoallelic 1p32. So biallelic deletion 1p32 was independently associated with inferior progression-free as well as overall survival on multivariate analysis. They also showed that patients who have biallelic 1p32 had associated secondary abnormalities such as deletion 17, 414, which also added to the prognostic value of deletion 1p32. This is one of our recent studies that looked into concomitant presence of both 1q21 and deletion 1p. So as expected, when you have two high-risk events, the patients had really poor progression-free and overall survival. So in our analysis, which also included about 1,000 patients with newly diagnosed multiple myeloma who've got a tandem autologous stem cell transplantation, the concomitant presence of both 1q21 and deletion 1p was independently associated with inferior outcome on multivariate analysis. So this is actually a slide that simplifies the current IMWG consensus definition on genomic high-risk multiple myeloma. As I alluded to before, the deletion 17p and TP53 mutation standalone is ultra high-risk myeloma. Biallelic deletion 1p is also standalone high-risk, ultra high-risk event in multiple myeloma. For the rest, it's usually a combination of these abnormalities. Translocation 414, 1416, and 1420 are all high-risk, ultra high-risk events when they occur along with deletion 17p, TP53 mutation, or a biallelic deletion 1p. So I just wanted to go over some of the risk stratification tools that we use in the clinic. As we all know, RISS is the most commonly used risk stratification tool in newly diagnosed patients with multiple myeloma. So this is based upon readily available laboratory data, beta-2M, serum albumin, LDH, and also it includes cytogenetic abnormalities 17p, 414, and 1416. The RISS staging system actually classifies patients into 3 groups, but the caveat here is that majority of the patients fall in the ISS stage 2, that is the yellow curve here. It's a large group and it's a clinically heterogeneous group. So we really need better risk stratification to identify, and further risk stratify these patients, particularly the patients who belong to the RISS stage 2. The Mayo additive staging system is another recently incorporated staging system. And as the name alludes to, it is an additive staging system. It incorporates 1q21, 1416, in addition to 1420, 414, and deletion 17p. R2ISS is R2ISS, or the second revision of ISS staging system, is another staging system that was introduced by our European colleagues. So this actually builds upon the ISS staging system and incorporates additional cytogenetic abnormalities, that is 17p, 414, and 1q21. So again, of note here, they have not included 1416 into the R2ISS staging system. So the R2ISS staging system identifies patients into 4 different groups with distinct clinical outcomes. The other risk stratification tool that are available out there is the RISS 1q staging system that was published by our German colleagues. And then we have more recently a personalized scoring system that was recently published by Ola Landgren and the group in JCO. So the existing staging system have several issues. One, they don't identify patients who are functional high risk. We all know functional high risk is really an unmet need. So these are patients who have poor outcomes, who have early relapses following autologous stem cell transplantation, and they're not patients that we can identify by the standard risk stratification tool that we have. Additionally, all these studies have been done in the setting of the older, induction regimen, which is VRD. And nowadays we use CD38 monoclonal antibody, either daratumumab and isatuximab in the upfront setting. So these risk stratification tools are not really validated in the CD38 monoclonal antibody-based induction therapy era. And we know that novel imaging is another important risk stratification method, and none of these tools have incorporated novel imaging into their algorithm. And that's really important because we have a lot of data, both retrospective and prospective, showing the value of novel imaging in patients with both newly diagnosed as well as relapsed refractory multiple myeloma. So I want to briefly go over gene expression profiling in multiple myeloma. So the gene expression profiling is an important step in elucidating the molecular heterogeneity of multiple myeloma. So the UAMS Myeloma Center actually were pioneers in this. They were the first in the world to introduce the gene expression profiling in multiple myeloma. They call this the UAMS 70 gene scoring system. So this was based upon gene expression profiling data, and they identified 70 genes that was differentially expressed in patients with high-risk disease. And interestingly, majority of these genes were mapped to the chromosome 1. So they really showed back in the day, some decades ago, that chromosome 1 is really an important prognostic tool in multiple myeloma. So the UMS 70 gene profile is a validated tool, and it can identify 13% of patients who have high-risk multiple myeloma. There are other gene expression assays that are available. However, these are not really widely adapted in clinical practice because they're not standardized and none of them are currently FDA approved for use. We do use them in a clinical trial setting. One of the clinical trials that have incorporated gene expression profiling, that is the SKY 92 assay, is the Optimum trial from the UK. So in this study, gene expression profiling defined high risk was one of the inclusion criteria. So they really show how this could be incorporated into the modern day clinical trials. So this is actually a paper by Dr. Kaiser and colleagues published in the British Journal of Hematology. They show that if you were to use gene expression profiling, that is SKY 92, you could identify 10 to 15% of high-risk patients that could otherwise be missed if we were to just use standard genetics such as FISH and cytogenetics. So circulating plasma cells and plasma cell leukemia. Circulating plasma cell represents a subset of clonal bone marrow myeloma cells, which has a distinct transcriptional profile. So the circulating plasma cells tend to have reduced expression of integrin adhesion protein, and they have lower dependency on the bone marrow milieu and increased ability to egress into the peripheral blood. We think that these circulating plasma cells have a higher clonogenic potential, and this could contribute to the distribution of myeloma in the extramedullary site. So these are actually two large European studies that was published in JCO in 2022. So this is in a patient population that is transplant eligible, newly diagnosed. And here circulating tumor cells was detected by Euroflow assay, which is a sensitivity of 10⁻⁵. So the authors here showed that the presence of circulating tumor cells, that's 2 or more percentage, was associated with inferior progression-free and overall survival. Additionally, the same edition of JCO, they had another publication now from the Forte trial. Forte trial is an Italian trial that enrolled patients with newly diagnosed multiple myeloma and had transplant incorporated into the trial. So in this study, circulating tumor cells was detected using multi-flow color assay with a sensitivity of 10⁻⁴ to 10⁻⁵. And they here showed the same finding pretty much, that a high level of circulating tumor cell was associated with inferior progression-free and overall survival. And this was true on multivariate analysis incorporating well-established risk factors such as ISS stage, cytogenetics, and LDH levels. And in the study, they also showed that MRD negativity was the most important factor that can modulate the adverse prognosis of circulating tumor cells. So taking all this together, the new International Myeloma Working Group consensus definition defines the presence of more than or equal to 2% circulating plasma cells as an ultra-high-risk feature in multiple myeloma. I also want to briefly discuss the evolving diagnostic criteria of primary plasma cell leukemia. So in 2013, the International Myeloma Working Group put forth the definition of plasma cell leukemia, whereby patients who had circulating plasma cells of more than or equal to 20% on peripheral smear qualifies for a diagnosis of primary plasma cell leukemia. More recently, the IMWG introduced this new criteria for primary plasma cell leukemia. Patients who have circulating plasma cells of more than or equal to 5% now qualifies for a diagnosis of primary plasma cell leukemia. And as expected, with the lowered threshold, the incidence of primary plasma cell leukemia has gone up from 2% to 3 to 4%. So coming briefly to another important aspect of risk stratifying multiple myeloma patients, novel imaging in multiple myeloma. So these are some of the acceptable imaging strategies that we use currently for patients with multiple myeloma. In our practice, we try to get a PET-CT. I'll go over the data on MRI DUPS, but MRI DUPS is pretty much the gold standard for detecting bony focal lesions in patients with multiple myeloma. In an ideal world, these are complementary tests, and PET-CT and MRI DUPS should be ordered together, if possible, in all patients with newly diagnosed multiple myeloma. So this is actually one of our patients. So why is X-rays considered obsolete in 2024? So the slide here shows X-ray and MRI done simultaneously in this index patient. If you look at panel B, the X-ray appears normal at diagnosis, and the corresponding MRI DUPS that was done is also reported as normal. But over time, the patient develops additional bony focal lesions. So here, the X-ray done at that time pretty much is normal, but then the MRI DUPS now picked up two bony focal lesions involving the sacrum as well as the lesser trochanter. Thus, we know that X-rays are suboptimal tests, and they can fail to capture these important findings that are of clinical significance in patients with multiple myeloma. So PET-CT, as we all know, measures the glucose uptake, and it is an excellent test to detect extramedullary disease. However, there is 11% false negative rate that is related to the deficiency of the hexokinase enzyme that are important in glucose metabolism. That was actually described first by Dr. Rashi and colleagues at UAMS. And then we have MRI DUPS, which measures water mobility. So the MRI DUPS is really the gold standard for detecting bony focal lesions in multiple myeloma. The advantage of MRI over PET-CT is that there's no dietary restrictions involved. You don't need to ask our patients to fast. There's no radioactivity involved as such. However, the disadvantage of an MRI DUPS is that it's not a good test to detect extramedullary disease. So thus, in an ideal setting, both PET and MRI DUPS are complementary and should be ordered together, if possible, in patients with multiple myeloma. So what's the data that we have on PET and myeloma outcome? Again, this comes from the UAMS Myeloma Center, where they showed that presence of 3 or more focal bony lesions at diagnosis confers an inferior progression-free and overall survival. I just also want to show what a normal PET looks like, and this is a highly abnormal PET in a patient with multiple myeloma. So we also have similar data coming out of MRI DUPS. Again, Dr. Rashi and colleagues from the UAMS Myeloma Center showed that presence of 3 or more large focal lesions on MRI DUPS conferred inferior progression-free as well as overall survival. Another important aspect in risk stratification patients with multiple myeloma is the way they respond to therapy. So I want to introduce this concept of primary refractory multiple myeloma. So this is actually data from the Mayo Clinic. It's a single center study that included nearly 1,000 patients with newly diagnosed multiple myeloma. In the study, patients received upfront triplet regimen of VRD or KRD, and a small subset of patients also received quadruple, that is CD38 monoclonal antibody therapy, which is currently the standard of care in the United States. Fortunately, the incidence of primary refractory disease have decreased with modern day therapy. We can see here that with a triplet induction regimen like VRD, the incidence of primary refractory disease is 7.4%. It's come down to 2.5% in patients who receive a quadruple induction therapy upfront. We also see here that the patients who have primary refractory disease have an inferior overall survival of nearly 4 years compared to 11 years in patients who respond to upfront therapy. primary refractory disease, thus overall has inferior outcomes. This is one of our studies where we showed similar data using MRD. So in this study, we included patients who had serial MRD assessment from diagnosis, irrespective of IMWG response criteria. So patients who had a response still got a bone marrow and MRD assessment by the Euroflow assay, which is with a sensitivity of 10⁻⁵. So here, patients who had a persistent MRD disease had an inferior progression-free and overall survival. If you look at the overall survival, it's pretty much similar to what we see with primary refractory disease. Thus, persistent MRD disease is really the new primary refractory disease. And this is obviously worse in the setting of gene expression profiling high-risk disease, as shown here in the curves in the bottom. As I stated before, early relapse following autologous stem cell transplant is another poor outcome. This is what we call another functional high-risk group. And these are patients that are being treated with upfront CAR T-cell therapy in the new KarMMa and CARTITUDE study. There's actually some data being presented at IMS based upon ide-cel in this subset of patients. So this is data from our European colleagues that again had about 2,600 patients treated with autologous stem cell transplantation. They identified about nearly 20% of patients had early relapse within 18 months of starting therapy. Early relapsing disease was enriched in patients with ISS stage 2-3, ultra high-risk disease, and had fewer responses, VGPR or better, to therapy. Here, the 5-year overall survival in patients who relapse early from initial therapy was about 80%. And when we look at the curve here, early relapse in the setting of high-risk disease, that's the dotted curve here, had a poor outcome, which is true also for standard disease patients who had an early relapse. Thus, it's important to incorporate all this when we risk stratify our patients to therapies. So this is actually a figure that shows pretty much that we have to take into consideration disease, patient, as well as treatment factors when we make these decisions. And these are all very important when we decide therapy for our patients. So this is the proposed IMWG working group consensus definition. As I discussed before, ultra high-risk disease is either the presence of biallelic TP53 inactivation, and the presence of more than or equal to 2 high-risk features that does qualify for ultra high-risk myeloma. Then we have high-risk GP signature extramedullary disease, the presence of more than or equal to 2% circulating plasma cells, primary refractory disease, or early relapse within 12 months after first-line therapy also qualifies as ultra high-risk disease in the current IMWG consensus definition. The rest of it is actually high-risk myeloma. So I also wanted to show you this figure. It's pretty much what I described before. So we have standard risk myeloma with excellent outcomes, with survival ranging from 5 to 15 years. And then we have the ultra high risk, where the survival is approximately 2 to 3 years. And then we have the high risk here in between, which is defined by all these features, where the outcome is intermediate between standard and ultra high risk disease. So what did we do for our patient? So our patient has IgG kappa multiple myeloma. She has RISS stage 2 disease. So how do we proceed with treatment here? So how do we risk stratify this patient? The patient did not have any high-risk genomic features by FISH. Novel imaging studies were negative. So how did we adapt therapy for our patient? So this patient is transplant ineligible mainly because of our age cutoff of more than 75. We know that we have seen recent data on lack of efficacy when the melphalan dose is reduced to 140 compared to 200. So we've increasingly going away from doing MEL 140 transplant. So the patient in this setting will proceed with a quadruple induction regimen of isatuximab VRd based upon the recent IMROS study that was published in New England Journal of Medicine and was also presented at ASCO 2024. So in conclusion, risk stratification is a dynamic and evolving concept in multiple myeloma. And we always want to take risk stratification in the context of the current treatment landscape for multiple myeloma. Disease treatment and patient-related factors are complementary variables in risk stratification. Risk stratification is critical for predicting prognosis and making therapeutic treatment decision. Ultra-risk, high-risk group continues to have poor outcome despite therapeutic advances in the field. Thank you for your attention. I would like to thank our patients and family for their contribution to the progress of clinical and translational research. This is my entire team, our collaborators, our funding sources. And this is actually pictures from a recent fundraising trip that we did for myeloma. These were pictures taken at 17,000 feet from the sea level. This is the highest point of a 30-mile high altitude trek. Thank you for your attention.
Thank you, Dr. Meera. That was an excellent presentation. You covered the topic very well, and you extensively described the journey where risk stratification has slowly evolved from an ISS staging to all the way to new genomic expression profiling. So we have a few questions from our audience. As far as the TP53 mutation is concerned, how does the VAF play a role when it comes to risk stratification?
How does, sorry, what was that? NGS? What did you say?
As far as the TP53 mutated myeloma is concerned, how does the VAF, variant allele frequency of TP53, play a role when it comes to risk stratification?
So, TP53 mutation, when we do it, it is of clinical significance. So, even the presence of even a small clone, I would clinically take it very significantly, because we have enough data that shows us a biallelic, chromosome 17 event is important, poor prognostic factor. So, in my clinical practice, a few patients that we have done NGS on, any TP53 mutation is considered of clinical significance. But for the FISH cutoff, I think currently what is accepted is a 20% cutoff. The French group had the 55% cutoff, but the new consensus definition, actually, they lowered it to 20%. I mean, these are very evolving and dynamic definitions, but then currently 20% for the International Myeloma Working Group is the accepted standard.
So we had a patient who was diagnosed with smoldering myeloma, but on the FISH, there was deletion 1p. So couple of questions. One is, in patients where you're evaluating for an MGUS or a smoldering myeloma, do you routinely do a myeloma FISH panel? And if yes, based on the abnormalities and cytogenetics of FISH, will your management change?
That's a good question. So all patients who, we are obviously a tertiary center. So all patients who come to us, we do a very comprehensive workup, which will include a FISH analysis as well as novel imaging for even the precursor conditions. But then if I were to find a secondary event like deletions, even if it is 17p deletion in the setting of smoldering myeloma or MGUS, we really don't offer any treatment. So with smoldering myeloma, obviously the field is divided, right? So we as a group don't offer upfront treatment for our patients with smoldering myeloma. Even they are high risk outside of a clinical setting, we really don't offer treatment. The primary reason is that there has not been a study that has convincingly shown us that treating high risk myeloma improves quality of life or improves overall survival. The two studies out there have their own, they have their own issues, which is another topic. But currently, we don't treat patients with smoldering myeloma, even if they have 17p deletion or chromosome 1 abnormality.
And do you think
outside of a clinical trial setting? Sorry, in a clinical trial, we obviously have treated patients.
In India, as you must be aware, we have financial constraints when it comes to baseline investigations. So do you think if we are doing a myeloma FISH panel for all patients, should we still do a cytogenetics as part of baseline risk stratification?
So it all depends on, I understand the limitations in our resources that we want to allocate it to, patients who need it the most, right? So the risk stratification is important only when we can adapt therapy accordingly, right? So let's say that if you were to find a biallelic TP53 event, are you going to adapt your therapy? That's some important question. Even currently, we don't adapt therapy. So all patients who come in, even if they have the upfront therapy is the same. They get data or isatuximab along with VRD upfront transplant. Then they usually enroll on a clinical trial in the maintenance setting. But then we also have CAR T cell therapy available in the second line, right? So these are some of the patients that I might consider, CAR T early as standard of care, or patients if they have a clinical trial in that setting, I might consider it. But it all depends on the, you have to take how are you going to adapt therapy? That's an important consideration,
So in your practice, for these high-risk patients, do you think CAR T-cell therapy overrides or overcomes the adverse prognostic impact of these mutations? I know it's a question which a lot of us are trying to answer, but what is your experience with this?
So we know that there's an ongoing study that is enrolling CAR T versus transplant in the upfront setting, right? So hopefully we will see some of those results in the next several months to come. There's also this trial of upfront CAR T versus standard of care in patients who are not transplant eligible. So all these trials will help us understand. But we need to understand that CAR T therapy currently, as it is currently, it is a higher risk procedure. It's a high benefit, high risk procedure. We know that the non-relapse mortality with cilta-cel is about 15% compared to less than 1% with transplant, right? So we do over 100 CARs per year just for myeloma. So we have seen that over time, this is something that needs a close conversation with patient, especially with the risk and benefit. And as far as we know, especially in the relapse setting, post-CAR relapse are very common. It's not a curative treatment. So, really, we don't have that data. But so I would offer, obviously, CAR to a patient upfront if the patient has high risk or ultra high risk disease in a clinical trial setting. I would offer that to a patient, having said that.
Even our practice is very similar. We offer a quadruplet therapy to all newly diagnosed patients if they are affordable. Dara VRD is our go-to choice as a first-line treatment. We have a patient who's 54-year-old, normal cytogenetics, deletion 17p was negative by FISH, but on NGS, we had TP53 with a VAF of 4.54%. So how would you interpret this? Would you consider this a high-risk disease, or could it be a chip? What is your take on this?
So this is NGS done the bone marrow, right?
This is NGS done on the bone marrow, yes, but not on the enriched plasma cells.
I see. Yeah, so again here, it's just a monoallelic event, so I would not change my treatment. I would, continue with, quadruple induction followed by upfront transplant if the patient is eligible as such.
But as far as the risk stratification is concerned, would you still place this patient as a high risk?
So this patient, per the International Myeloma Working Group, is, you don't need to have. This is actually an ultra high risk event per the international. I mean, the cutoff is really not well defined by NGS, but then this according to the International Myeloma Working Group consensus definition is possibly an ultra high risk patient.
What is the role of trisomies and tetrasomies when it comes to risk stratification? Because very often we get trisomies, tetrasomies as part of the initial risk stratification. So where would you place them? If you have multiple, we had a patient who had 3 trisomies at baseline. Would that still be standard risk?
So trisomies are considered standard risk. So it all depends on how you actually do the, the karyotyping, right? So karyotyping. So in my mind, like the plasma cells have a low proliferative index, but then if you detect anything on karyotyping, they are not your normal well-behaved myeloma. So if there is a karyotype that is positive, I consider them as really not standard risk. I would consider them as patients who could possibly have, they're not going to have the well-behaved standard risk myeloma in my mind. So just because we know that anything that grows outside in a petri dish has to be, cannot be benign is what I meant. So. But all depends on the ability of the cytogenetic lab. Our lab here also, it's we do have issues with karyotyping as such, and with most patients coming back negative. So
Absolutely. We, in fact, face the same issue. Despite doing the karyotype and all everything on enriched plasma cells, even then we have a lot of issue in getting reports. Many times the metaphases do not grow or we get a negative report. But having said that, in patients who have a positive, who have a cytogenetic abnormality, should that be followed up when we do subsequent marrows? And can that be used as a crude MRD marker also?
Yeah, obviously, if the cytogenetics comes back positive and the bone marrow is morphologically negative, I would consider as this is, this is something, there are residual cells for sure, that for sure. Having said that, there's this excellent paper by Dr. Sawyer, and he's one of the first persons to actually describe chromosome 1 abnormality. So you guys should refer to that. I don't know how his lab can grow. It's always positive. I don't know how that happens, but yeah. But again, when you follow these patients, serially, how are you going to adapt therapy? That's the most important thing that you have to keep in mind. So some of our patients who have relapsed disease, I don't really routinely order bone marrow, because what am I going to do with the bone marrow? Unless they're on a trial, or there are some, like if they're pancytopenic, I'll get it because I don't know if the patient has underlying MDS, and we are increasingly seeing those, especially in the post-CAR setting and all that, right? So in those settings, I make sure that all patients who get CAR gets a bone marrow before CAR, because we have had several MDS-like or CHIP-like events that do pop up, and those are patients that I might not do a CAR, as of now, because we are increasingly seeing myeloid malignancies post-CAR. So, but then routinely on patients with relapsed disease, I don't order bone marrows, and I don't really follow FISH and cytogenetics as such.
What proportion of patients in your practice have a deletion 17p without a TP53 mutation?
So about 10, about 10%, like less than 10% of patients.
And many times we don't have a deletion 17p, and the other way around, we may get TP53 mutations on the NGS. So you mentioned in your talk, one of the areas where you would consider doing an NGS is to detect a biallelic TP53. But is there any specific subset of patients where you would do this? In other words, if patients have no deletion 17p on FISH, what are the probability that there can be a TP53 mutation detected on the NGS?
So we really don't know the exact prevalence of that as such, right? So what we do, like what we all do in this country, is that there is a deletion 17p, then we look for mutations in the other alleles. So that's why NGS is really nothing. It's not something that we do in clinical practice. We do obviously when we have a translational, research project going on, but otherwise that's not something that we do. So this is similar to what we all do in the mantle cell space, right? They look for biallelic event only when there is one FISH defined event.
And you mentioned about the prognostic significance of the NSG2 breakpoint. How do you look at that in your routine clinical practice? How do you look for it?
So obviously, this is this is one paper from the European colleagues that actually tells us that 414 is a very heterogeneous group. So I think we already knew that 414 is a heterogeneous group, right? So again, but the current consensus definition does not get to that granular detail. So patients with 414 is considered high risk, not ultra high risk, but high risk. I mean, isolated 414 is a high risk feature. So in my practice, I don't really see the clinical value of further risk stratifying this patient, because I don't have a therapy that I can give to patients with an NSD2 breakpoint, 414 translocation. They are sensitive to a proteasome inhibitor, so I try to make sure that patients get 414 translocation. I'll be very vigilant in the post-transplant maintenance setting. I try to give these patients a doublet maintenance, like daratumumab or isatuximab with Revlimid, or preferably on a clinical trial setting. And these are patients where small changes in their serum markers would be alarming, and these are patients that I would be super vigilant at this point.
I think you've raised a very valid point. No matter what we look for, ultimately, we need to look at whether we are going to change our clinical practice, whether it is going to affect the treatment. So
Exactly.
I think that's a very important point. Now, moving on to patients with extramedullary disease, very often we have patients with significant extramedullary disease but no increase in plasma cells in the marrow. So we may have plasmacytomas with multiple lytic lesions, but the bone marrow does not show significantly increased plasma cells. How do you restratify these patients? And do
So
you do
these
that
are,
on solid tissue also?
what did you say, Nikhil? What was the last part? Can you please
Yeah,
repeat?
number one, how do you restratify these patients? And do you do the myeloma FISH test on the biopsy specimen of plasmacytomas also?
Yes, so this is actually an important, topic, especially now that we see all this post-CAR lapses, right? So in the upfront setting, this is what we call a macrofocal disease or oligo or non-secretory disease. Actually, this was described, macrofocal, that term was coined by Dr. Rashi and colleagues from the UMS Myeloma Center. So this is actually rare in the newly diagnosed setting, but we see a lot of this in the post-CAR and post-bispecific relapse setting. So, so what we do, so in the relapse setting, I don't even get a bone, I don't really get a biopsy of the extramedullary or a plasma site, because it's not how am I going to change therapy anyway? So that's why I don't really biopsy it. But in the newly diagnosed setting, if the patient does not have bone marrow involvement, I do biopsy whatever is feasible, and FISH studies will be done there. But again, we know that there is a lot of clonal heterogeneity, right? So even if I biopsy one of the plasmacytoma, that's not representative of what the other plasmacytoma will look like. So I'm not sure about the clinical significance of it, but a patient who presents with multiple extramedullary disease, for example, liver involvement or skin involvement, all that upfront is it's a high risk event. So I would be very vigilant. These are patients that I might, even do an upfront CAR, like autologous stem cell transplantation with early CAR. This is somebody but in the lab setting, we don't biopsy these. We know this is a high risk event. We just treat them with the best available therapy in that setting. There's no point in this is where the liquid biopsy comes in play, and we really don't have a good way of, detecting this. But then maybe in the future, Dr. Paiva and the group might have some kind of very good liquid biopsy methods whereby we could just, get a blood work and can understand what this different extramedullary disease is genomically composed of,
So taking that forward, there are many trials which are coming up, which are looking at the role of ctDNA in risk stratification as well as prognostication. Going forward, do you see them coming up in your clinical practice in a big way?
So the issue with ctDNA is that, in solid tumors, it's a different story, right? So they do that in solid tumors and all that. But in myeloma, the issue is we don't know what is CHIP, what is myeloma, right? We really don't know. So that's the problem. So that is something that needs further, unless we have a very good sensitive assay, which is obviously there's ongoing work, to identify that sensitive test. We don't have that at this point. So, but I'm hoping that in the future we will have better technologies that can help us really identify that myeloma clone that we can follow serially. Mass spec is an important test in this assay, as well as serum BCMA level is another important, risk stratification tool, which I did not mention about, because there is actually data that tells us that the serum BCMA level, which is an ELISA-based test, right? That actually correlates with the tumor burden, and it might be a useful test in those oligosecretory and non-secretory myeloma. There's obviously, a lot of data on that, and we'll see more data at ASH also on this particular topic, the serum BCMA level and tumor burden.
So if we are doing an NGS for myeloma patients, do you think it should be done specifically on enriched plasma cells, just like how we do a FISH test, to avoid picking up chips?
Yeah, there's a lot of heterogeneity in the way that you isolate plasma cells too, right? So for example, even with FISH, which we do on CD38 selected cells, right? So the way that, the way we do it here is we do the CD38 selection, and then there are other centers that look at, they do the IgG, the intra cytoplasmic IgG cell. There's the way you can select for those cells. So I really don't know which one is the right way of doing it. So I anticipate there'll be a lot of heterogeneity. Even with FISH, we have heterogeneity. So I'm not sure about what will be the ideal way of doing NGS, because as far as I'm concerned, NGS is not something that is it's not something that I could reliably use in clinical practice as of now, So I don't know what will be the ideal way of plasma cell selection, but it'll make sense to do plasma cell selection for sure,
So the reason why we asked this question, we had an interesting patient with a relapsed myeloma, refractory to multiple therapies. When we did an NGS, a BRAF 600E mutation came up. But
Mhm.
as part of a thought process, we thought, why not look at it in CD38 selected enriched plasma cells? The mutation wasn't there, which got us thinking whether the initial mutation we detected, was it a chip? So that was the reason why we asked this question.
So obviously, BRAF mutations and they are present in a subset of patients with multiple myeloma, right? But that's not a chip-defining event either. So that is why, as you rightly said in the beginning of the talk, that when you do NGS routinely on patients, you have more questions than answers. But we obviously were part of this, study that used BRAF and MEK inhibitors for multiple myeloma, right? In those studies, most of the clinical trials will need you to biopsy that particular, it's a plasma cell. It should be present in the plasma cells. So for our patients to be eligible for BRAF or a MEK inhibitor, for sure.
And just to deviate slightly off the topic, in relapse setting, what is your experience with BRAF inhibitors? Do they work in multiply relapse patients where we don't have many treatment options left? Do you think vemurafenib and other BRAF inhibitors can be viable treatment options?
I mean, they will. I mean, see, so currently the bar is so high, right? With bispecific and CARs, we are seeing upwards of 70 to 90% responses. So obviously, your MEK inhibitors and BRAF, inhibitors, these are not agents that produce those stellar response. We could see an overall response rate somewhere in the 20 to 30%. So I'm really like in 2020, I think when I started here, at that time we were looking for all these new therapies, but currently in 2024, I don't really see a role for this kind of precision medicine in myeloma. The only space where I would use a precision medicine kind of treatment is patients with 11-14 translocation. That's the only. But I don't think there's a future to. I mean, there is obviously a study that was published by the German colleagues. I think it was in Blood last year, so that they do report. But there are no ongoing studies as such.
And a couple of questions before we wind up. There's a lot of excitement around AI-based tools for risk stratification and AI-based risk stratification models. I know it is an experimental and a lot of research going on in it, but do you think they can address some of the limitations that we currently have in our myeloma risk stratification, where we take into account only the disease biology, but not the response to transplant and many other factors which are maybe far more important?
I think as a field evolves, obviously AI is going to be everywhere, right? So that's something that I do anticipate would change in the future. But then on this line, when we're talking about personalized risk stratification tool, there was indeed a paper by Dr. Ola Landgren and Francesca Mora, and that was published in JCO this year. So they are actually, so it's actually a more of a translational or genomic paper that looks into what they call a personalized risk stratification tool for myeloma. That's something that would be worth a read. So this is actually based upon all this. They build up models, and they even can predict who are the patients who will benefit from an upfront transplant. I think it's a real cool paper to read. So that's that but I do anticipate that things will change, and it has to change, right? Because our current risk stratification tool does not incorporate any of the, it misses a lot of things that are that we know are clinically important, isn't it?
I think we have answered all questions from the audience as well as which we have collected from our colleagues. So, Dr. Meera, it was a pleasure interacting with you. The question and sessions was wonderful. You answered all our questions patiently and presented a lot of data, a lot of things that we can go back and read up. It was an excellent experience for all of us, as well as the audience which has joined in. We have more than 250 people who have joined us from 7 different countries. So all of them, I'm very sure, had a great experience listening to you. Again, wonderful talk. And thank you so much for sparing your time on a Friday morning and joining us for this interactive session. We hope to have more sessions like this and collaborations with you in the future. Thank you, Dr. Meera.
Thank you, Nikhil, and thank you, everybody. Please let me know if you have any questions. My email and it's right here. So yeah, you guys don't need my slides, right, Nikhil? You're muted, I think.
Sorry. If you could share it with us, it would be great. And if anyone does ask for it, we'll definitely forward them the
Sure.
slides.
Okay, sounds good. Thank you. Have a good evening.
Thank you.
Bye.
On behalf of Fortis Institute of Blood Disorders, I would like to thank each and everyone who has joined in for this webinar this Friday evening. I would also like to thank the organizers and Emcure Pharmaceuticals for providing this platform for conducting the webinar. Thank you, everyone.